is Wikipedia, and found out that actually the origin of skin in the game has nothing to do with health and physical skin. And so I decided I can't hate the term as much as I used to. So I went in search of another, and actually it didn't take long. In fact, my most despised phrase, really ahead of skin in the game, is the non-compliant patient. You don't have to go to very many meetings with clinicians in the room to hear discussion of non-compliant patients. And I thought, since I'm reading my talk from the iPad, I can state with confidence that the Apple Corporation does not have a department of non-compliant iPad users. They take as a given that we are different, that when we pick this up, we think of it differently, we want to use it differently, our assumptions and expectations and knowledge coming in are different, and that they need to engineer to meet our differences as opposed to think of some of us as compliant and others as non-compliant. The problem, of course, is that designing for heterogeneity, which is a form, I would say, of co-design, as Karen referred to it earlier. It's a lot harder to design for heterogeneity than to design for homogeneity. We had years of industrial engineering and planning and simultaneous equations in the Soviet Union to figure out 5-year plans. It's really not, it's hard. With a mainframe, it's hard. With an iPad, it's probably a little easier to plan for homogeneity. But heterogeneity is more difficult, and designing for heterogeneity is much harder. So when I was asked to give this quick thought about patient activation, I had to start with, well, what do we mean? And I even noticed in a couple of the rooms that I went to that people were starting at somewhat different places. So from my perspective, which you are free to reject, the cornerstone of patient activation is demanding a healthcare system that's re-engineered around heterogeneity. Now that may seem like an odd place to start. I thought it was about eating right and exercising and the like, and I think that's true. But the reason I come at it from this perspective is that when I think about heterogeneity of patient characteristics, of patient preferences, of patient values, but also of the resources people bring, their ability to engage with a healthcare system, in order to be activated, you have to engage. And in order to engage, you only engage where you have a relationship. And relationships, need I tell any of you, are complicated. So if you don't build into the healthcare system an expectation of complexity and heterogeneity of the patient, it's very difficult to get patients to be activated because they immediately default to a passive mode. They don't see it as a relationship. It's much more of a consumer relationship in the way we think of it, and people use that term. But if we're talking about activating people and patients, they can't be passive consumers. They can't be shoppers. They need to be in a relationship. And so, as I say, from my perspective, if we're serious about patient activation, what we're serious about is re-engineering the healthcare system around heterogeneity. So you can already tell this is not a TED Talk because introductions have to be like 30 seconds. And I only got to my premise 4 or 5 minutes in, and someone's going to have to tell me when I'm running out of time because I did not exactly time this out. Okay, so if you buy the premise that in order to achieve the goals that bring you together tonight, we have to re-engineer around heterogeneity, where do we go from there? So first of all, let's think about the forces that are aligned against patient engagement. These are not hard to identify. Professionalism of the clinical sector is a well-known source of disengagement. I'm trained as a lawyer. You know, if you have someone as an expert, obviously the person you're interacting with doesn't know as much as you do, and so engagement becomes something that professionally you wouldn't be immediately inclined to do. Your training doesn't lend itself to that. That's very closely tied to the asymmetry of information. Well, what we know is so complicated, there's no way you could possibly understand it, so rely on me. And that's then exacerbated by payment models that now are very much process throughput oriented. So something like a relationship, which takes time and effort, we don't pay for time in that kind of a way. So these are long-standing barriers to patient engagement, but all of them are breaking down, some more or less, but physician and clinical education is changing. Information is being democratized. Payment models are in flux. So there's pressure on on the edifice that we're trying to tear down. What does it take to start a movement? If you look at the materials you were provided for today, there's one obvious catalyst to get people involved in a movement, which is matters of life and death. This is my life. I have cancer, I worry about polio, I worry about whatever the cause might be. That will break down a whole lot of barriers, and it gives people motivation, and it also gives them moral authority to demand change. That's great, but I think a lot of movements don't just call upon matters of life and death, although at one level all of these things are. On the list of examples of successful movements, there was one missing. In one of the rooms, people listed one that was not on the list. I'm going to name another one because I used to run the Medicaid program many years ago in Colorado, and that's the independent living movement among people with disabilities. Now, a lot of that movement is about life and death, but really what it is about dignity. It's about personal autonomy. A lot of other movements are about fairness. Americans, we're complex people in terms of our politics, but we are quite rooted in some social values, and fairness speaks loudly to Americans, and dignity speaks loudly to Americans. So I think we need to not just look at the life and death issues, although those are obviously top of mind, but if we're thinking about what it takes to get a movement going, we need to go into values beyond life and death. Three things that I would say it takes to get the movement off the ground once you have this sense of purpose. The first is overcoming the sense of inevitability of the status quo. And that's a big barrier in healthcare. It's a big barrier in any professionally dominated field because the experts will assure us cancer is a death sentence. Infections are an inevitable byproduct of being in the hospital. Yes, we can try to reduce mortality, morbidity, but these are not things we can eliminate. What starts to change is when we start saying, well, I believe you're doing the best you can, but if you engage me and my experience, we can do better together. That breaking down the sense of inevitability, I think, is critical. Otherwise, it's very easy for the professionals to retreat to the status quo. Second, and this has already come up in the reports back just a moment ago, is redefining the narrative. Movements are about narratives, and narratives come from real people. They don't come from experts and professionals, although they also have a narrative, and in my journal we actually invite those narratives as well. But fundamentally, mass movements are built on narratives and stories, and claiming experience as the foundation of a movement. That's what movements are all about. The third is the much more complex. I don't fancy myself an expert, and that's about the strategy of movements. That's what you're going to spend the rest of the evening on. When I look at successful movements, two elements that I think about the inside-outside strategy. So it's great to have a patient movement, but there are a lot of clinicians, many of whom are here, and there are a lot of clinically based organizations and institutions that want to be part of these movements. You have to include them as your allies. So it's not an us against them, it's finding internal allies. I always felt when I worked in state government that advocates often saw states as the enemy because they were not doing the things that they thought needed to be done. I said, the people inside, many of them are your allies, even if the institution has barriers to acting the way you think they should. So find this sort of inside-outside strategy. And the second strategy that's really critical is understanding the diffusion of innovation. Movements do not begin and explode of their own accord. Change does not happen all at once. There are leaders, there are early adopters, there are middle adopters, there are laggards. The way you approach all of those phases of movement and participants in those phases are quite different. So the biggest challenge, I think, in any movement of this kind, and you could say this about politics in general, is that I don't just have a law degree. I have a master's in public policy. One of the first books you read is where you learn the phrase windows of opportunity, and you learn that you have to sort of be prepared. You never know when something is going to happen that's going to put your issue on the front page, and so you're always in preparation mode. But those moments when the window opens are completely unpredictable, so you have to always be ready. But there are times that you can expect it to be more likely that the window will open, and those are at inflection points, and I really think we are at one. If I had a lot more time, which I won't take now, I would give another talk that I've given, but I'm going to give you the literally the 2-minute version because I do think it's important. You are a sophisticated healthcare crowd. We are in the midst, as you know, of major change in the healthcare system and changes in payment models and reorganization of all kinds. I won't try to characterize it. You all are completely aware of that. There is, however, I think, a big risk for patient activation in what's going on right now. And I want to pause and just, over dinner we can talk about this if you're interested more, but this move to value, move away from fee-for-service towards value and value-based payment, everyone thinks is a great idea, and I do too, except there are lots of ways that moving to value can quash a patient activation agenda. And I want to explain why I worry about that. Once you say you're going to pay for value, you have to define quality. Once you define quality, quality has to turn into a metric, something you can measure and count. Counting and measurement requires expertise and professionalism. It requires getting the experts in a room and saying what is high quality care. That runs, in my view, directly counter to what we have been talking about the individual narrative and heterogeneity. So if you ask the Institute of Medicine about the 5 elements of quality, patient-centeredness is one, but it tends to be the most poorly defined. It's a lot easier to measure blood glucose or whether or not someone got a mammogram than if the healthcare system is co-designed or if patients were engaged in shared decision-making. And so as we move to value as the metric, we run a real risk of eliminating the opportunity to celebrate heterogeneity because quality tends to be defined around medians and means and homogeneous populations. And I would love to talk to you about this for another hour or two, but hopefully at least I planted a seed. So just to pull it together, what I feel right now is that there are many things bringing down the historical barriers to patient activation through the democratization of information, through changes in medical education. We really are at a time of change. But, and the culture, I would say, the culture and thinking about healthcare really is changing. But we also are at a point where if we don't reach some maturity in patient activation, the way I've defined it as engaging, requiring an engaged healthcare system with patient heterogeneity, if we don't do it now, we run a real risk of having this whole creative moment of transformation in the healthcare system reorienting towards value and then reifying itself in a way that squeezes out all of the patient opportunities for patient activation that brought us here. So time is of the essence. Get to work. The forces of defining quality and bringing it to some closure in ways that squeeze out what we're trying to do, they're pushing hard. The good news is it's really hard work, so it's going to take them a while. But you don't have long, and this movement has to integrate into the changes going on in healthcare writ large in order for it to then become a platform we can build upon, as opposed to staying on the margins or having to wait for the next fight. So I'm very enthusiastic about the opportunity. I'm personally passionate about the importance, but I'm also telling you we need you to work really fast.
We have time for some questions. The only question you can ask Alan is why your article wasn't accepted.
Alan, I have a question.
Yes.
Larry Stern on the board here. Do you view the move to managed care being consistent with your theme of heterogeneity?
I think it is neither consistent nor inconsistent. I think conceptually, so part of the problem is managed care now, means too many different things. I think the move to more integrated systems that try to look at patient needs more holistically, try to reallocate resources in ways that address social determinants and social context. If that's part of what you're referring to in managed care, I would say that's consistent with patient activation and patient engagement, because it doesn't take long as you try those endeavors for the person doing them to realize that there's no one intervention and that they have to get to know and build a relationship with the patients in the population if they're going to achieve their goals. So in that sense, I would say it's positive. The flip side is that for many, the delegation of financial responsibility to managed care entities comes with it an expectation of achievement of certain quality metrics. And I mean, think of the Medicare accountable care organizations, 33 quality metrics. I understand the need for parsimony, and I understand the cost, the burden associated with measurement. I understand that it's difficult for any organization to manage to lots of different goals. I totally get why 33, I don't know if it's the right number, but it shouldn't probably be 133, and it probably shouldn't be 3, so why not 33? But in that world, and there are CAHPS measures in there, there are patient satisfaction measures in there. But I don't think patient satisfaction and patient engagement are really the same thing, and I don't think patient satisfaction and co-design are at all the same thing. So I see opportunities, I see risks. Hard for me to say whether net it's plus or minus.
Thank you for your enlightening presentation. I really liked it. Stimulated me.
He's just saying thank you. It doesn't matter.
Thank you, and I thought it was brilliant, and here's why. Current quality teaching tells us that variation is bad, because we borrowed that from industries where variation is bad, when we're making Toyotas, et cetera. Now we're talking about human beings, and every single one is different every single day. So the skill set of the primary care team to know and engage and focus on something for that patient is what we need to do every day. So you challenging us to be patient-centered against value-based. Value-based really is about resource, conservation. So it's a very interesting thought and concept. Thank you very much for it.
So I'm glad you like it, but now I'm going to make you uncomfortable for a second.
Good luck with that.
Because what I want to make sure is that we don't overcorrect and go back to another common problem that we know from the real research around variation, which is that individual clinical decisions made by individual clinicians are often not evidence-based. And there's a big gap between saying we need everything to be, we need to engineer all the difference out, a la Toyota, and we need to just rely on individual clinical judgment. And what we need to do is make sure we're somewhere in here. So my only caution that we don't use it as an excuse to not assure that we're bringing in the best possible evidence.
That's team design, system design. Thank you very much.
Thank you. And I also appreciated your comments. I also think that there are ways to measure performance that are not going to lead to homogeneity, that can lead to heterogeneity. I think it's a matter of how you actually bring in the voice of the patient and measure their feedback, not their satisfaction, but their feedback and their engagement and alliance with the caretaker or the provider. And it's just not something that we currently do very well, but I think we can do better.
So I totally agree. And all of our quality measurement enterprise is still immature, and what I worry is that the clinical metrics advance more quickly than the ones you're describing. I also worry, since you asked, and I told you I could talk about this for an hour, and therefore I'll at least take another 2 minutes. I also worry about payment models that even if we do measure it, the question is, how do we then compensate for it? So we have the big announcement now that Medicare is going to do bundles for total joint replacement. That's a variance reduction strategy, at least on the cost side. Of course, the challenge with bundles is you don't get a bundle until you've already made the decisions you're going to do the replacement. And we have huge variability and very poor ability to engage with patient preference at that stage. And so you run, you run risks. I don't want to overstate them, but I also don't think we can ignore them. That within the patient population that might be clinically indicated for joint replacement, that there's a range of comorbidities and health status that are likely to yield better or worse outcomes. And lo and behold, when you're getting a bundle, it's a lot better from a financial perspective to replace the knee of a relatively young, relatively healthy person than someone who's really quite disabled in other ways and is going to have a tougher road out. And we can risk adjust and all of those things, but that's another area where our we can say it, but we don't do it as fully as we can. So I'm just trying to get at this notion that there are all these risks associated. I'm not saying I'm against it. I'm just saying if we're trying to build this movement, we need to understand how it relates to other things that aren't very well designed. But I do agree with you that we're getting better, and we have had papers and will continue to do papers as we get better at measuring patient experience. Someone's going to have to.
We're okay. We have 5 more minutes.
Okay, all right.
Jerry.
I'm holding the microphone, so that's. But I have
But he's holding the controls.
Yes. I have a comment and a question, because I'm not sure today, are we talking about patient activation, which is a sick care system term, or is it individual or community activation for wellness?
Well, I didn't call this meeting, so I don't think there's any question that we want the broader, the larger, the population activation. I do think that we have more tools for from my perspective, it's easier to sort of build backwards. If the health system is more engaged with patients, it's easier to then move out to a broader population. But I could be wrong about that. These maybe are 2 totally separate interventions. Getting people to walk may have nothing to do with re-engineering the healthcare system to be more responsive to patient needs. I tend to think of it as a continuum, but it's a great question.
Thanks.
And a question back here. Dr. Block, I presume, could someone give him a microphone? Great, thank you.
I've become disappointed with the term patient-centered over the last few years, and I'm wondering, can we move to person-directed? Are we ready for that?
Well, so I guess that begs the question of which person. So some people say, well, it should be patient and family-centered, which depending on what you're talking about, might be an improvement or might not. I mean, what I worry, so.
I'm not talking about person, I'm talking about directed.
Directed. So it's the directed side, not the centered side. I leave it to those who are better at putting smart words up on whiteboards to decide what the right word is here. It's a great question. I can't answer.
Is there a transfer of control that we're talking about, or is it just being nice?
Well, I certainly think it's got to be. I guess I never thought centered was just about being nice, but.
I didn't either.
Good. Then as long as we know it's about.
The doctor I talked to says I'm already patient-centered.
Well, I think that gets back to the earlier notion about what we're measuring. I mean, if you measure satisfaction, you're talking about clean rooms, nice, being treated well, and having a parking space. If you're talking about co-design of your care, you're talking much more broadly. And I think, we are starting to realize that asking these questions that are really about satisfaction are missing the boat. So it's we're moving up, but we got a ways to go.
Thank you so much,
You're welcome.
Alan.
Hi, I'm Nancy Zients. I'm the Chief Operating Officer and Chief Program Officer of the Foundation. And I heard from Elliot that we must deliver messaging that matters, motivates, and is actionable. And I heard from Alan that we have to give you a sense of purpose and a sense of autonomy. And I have to give you logistical instruction. So I will make sure that they matter, motivate, and are actionable. So your first sense of purpose is we now have approximately 30 minutes for 3 stations and your bio breaks. So the time limit is 30 minutes. Here are the 3 stations that you have options for right now, because here's the autonomy part of it. You can do these in any order that you would like, or you can choose to skip any of them. You can go outside because we've arranged beautiful weather with Eddie Shaw, who is a massage therapist who will lead you all through stretching because you've been sitting for far too long. So that is available to you right outside. There's a door here and there's a door through the conference room the other way. You can also, as you go into the lobby area, you might have seen that Venture Outdoors is here. Because if we want activated patients, we would certainly like them to take advantage of some of the outdoor activities available in our wonderful region, and Venture Outdoors can share some of those with you. And then we also want to make sure that you are satisfied and have had a chance to eat. So you do not have to eat within your 30 minutes, but the plan is that within this 30 minutes, you will go into that center conference room, which you would have come into when you first entered the suite, and you will gather up your food. Because at 6 o'clock, you are to appear in the same conference rooms that you left before, ready to eat and continue with the assignment that we will talk about in just a moment. You do not have to bring drinks with you. There will be drinks including beer and wine in each of those breakout areas. We will deal with beer and wine addictions at the next session. For today, we want you to have some and enjoy. But not everybody has to do all 3 of those stations that I